Welcome to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I'm your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts from around the globe and around all aspects of drugs and addiction. Today's episode is sponsored by ISAC, the International Academy on the Science and Impact of Cannabis. Visit their website at isac1.org, IASIC1.org, to follow the science on marijuana. Friends, fentanyl is plaguing America. There is no safe drug supply unless it comes from a legal pharmacy. If you are around anyone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. Hello again, High Truth listeners. Get ready for some deadly science. I'm your host, Dr. Ronit Lev. As an emergency doctor, it's my job to keep people alive. And when people die during my shift, it's considered a failure. I never get used to it. In 2013, the medical community was under fire for overprescribing opioids. And so I researched every single person in San Diego County who died of a medication overdose and compared their autopsy toxicology report to prescriptions they received before they died. That year, 254 people died from an accidental medication overdose. Looking through the medical examiner's report, it was page after page, prescription after prescription of failures, and I call those the death diaries. The research was spooky. I saw the same prescription patterns in dead patients as I was with patients seeking drugs in the emergency department. I was communicating with ghosts who were warning me to save my living patients. I realized that being a good doctor can be like being a good parent. As a mother of 4 kids, sometimes I have to say no to my kids out of love and concern. And as a doctor, I had to say no to my patients to the requests of many prescriptions to keep them alive. The research changed my life as a physician and really understanding medication safety. The death diary research was repeated in 2015, this time by sending letters to providers who prescribed a medication before a patient died. The letters were not to shame the doctors, not at all. Doctors were victims of the opioid prescription epidemic. When I started my career as a physician, I was told I was not prescribing enough pain medications. I was taught not to judge someone else's pain. I was taught that no one gets addicted to pain medications if they use it for real pain. But I was taught wrong, and I embarked on a journey to fix that wrong in medicine and re-educate. I believe the mission is mostly accomplished. The medical community is no longer over-prescribing opioids, although there is still room for improvement and safe prescribing. Sadly, the current opioid crisis is much worse. The alarm sounded in 2013-2015 due to escalating prescription opioid deaths pale in comparison to the current illicit fentanyl crisis. Today, over 270 people a day dropping dead because of drugs, 60% of them from fentanyl. I think we can learn from history in addressing the current fentanyl crisis. And with that, let's hear our question of the day.
Hi, I'm Natalie Callahan, and I'm a physician assistant at a busy emergency department. I prescribe opioids and benzodiazepines for patients while doing my best to prescribe them safely. Dr. Lev, I really enjoy working with you and listening to High Truths. It's very informative. My question is about the death diary research you did in San Diego a few years ago. 800 physicians were found who prescribed medications to people who died. I wonder if we are still having a prescription problem anymore, or has this been solved?
Thank you, Natalie. I so very much enjoy working with you in the emergency department. You have a very kind and caring bedside manner and attention to detail in patients' concern. And thank you for remembering the death diary research that has really greatly impacted my life as a clinician. And to answer your question, I invited a researcher, an expert who worked with me on the death diaries and has a lot of information and expertise in that. Dr. Jason Doctor is the Associate Professor and Chair of the Department of Health Policy and Management, as well as Director of Health Informatics and Health Policy and Economics at USC, the University of Southern California. He specializes in behavioral economics and the use of choice architecture to affect policy in health and medicine. To learn more about Dr. Jason Doctor, check out the High Truth show notes. Dr. Jason Doctor. Doctor, welcome to High Truths.
Hi, glad to be here.
I am so glad to meet you again and connect because we've done such great work together. And you've been amazing to work with because any little idea or research idea that I have, you blow it up and make it huge and get into publications such as Science and very prestigious journals, which I can never think of even doing on my own. So great. I want our audience to get to know and meet you. So can you tell us about yourself?
Sure. So my name's Jason Doctor, and I'm a professor of public policy at the Saul Price School of Public Policy at the University of Southern California. And I trained as a psychologist. I actually trained as a clinical psychologist, but then I sort of re-specialized in the psychology of decision-making. And in doing that, I became very interested in physician decision-making. And I think that's the work we're going to talk about today. But most of my work centers around how to help physicians make better decisions and using what we know from the psychological literature to facilitate that.
So it's very interesting. I wonder if you can help regular people make better decisions as well from your knowledge as a psychologist and studying this.
I hope so. I mean, a lot of the principles that we apply, they apply to everybody, really. We like to say that physicians are people too. And so physicians have the same human foibles as the rest of us. And so we can apply many of the same principles that way.
Interesting. Maybe we can talk about some examples, but I want to understand your background, or you are an expert in behavioral economics. What does that mean?
Yeah. So about 2008, there became an interest in applying behavioral economics, but long before that, starting around the 1970s, psychologists became interested in economic models. So economists had this difficult task of trying to understand value in the marketplace and how would markets work. And to do that, they made some simplifying assumptions about how people behave. Most of those had to do with people behaving rationally. It turned out that if you assume that people behave rationally in all situations, they can always come up with the best option possible for them. We call that optimizing their behavior. Then a lot of the mathematics of economics really worked well and more easily, and it kind of greased the wheels for many of the economic models. And so psychologists got interested in whether these models were actually true, whether people actually behaved this way in real life, or if they were sort of fictions that were used to help make the mathematics easier and study things on a different level. And we found out that it turned out to be a really fruitful research area because the rational model of decision-making was something that you could put out there as a kind of a null hypothesis, or like we're gonna assume people behave this way, and then we're gonna do a study and find out if they do. And a lot of times they didn't, but they didn't in very predictable ways. And so we were able to revise the rational model in a way that was more descriptive and more accurate about how people behave, without having to come up with an entirely new way of thinking. We just would make these small changes.
Can you give us a practical example?
Yeah. So, one of the easiest examples to understand is what's called probability weighting. That people distort probabilities. It's very hard for us to really behave as if the chances of things happening match the numeric probabilities of them happening. So we often overweight small probabilities. We react psychologically to events that might, be fear-inducing, like an airplane crash. It's very rare, but we react to that, and so we behave as if it's much more likely to happen than it is. We're also, um, overweight the chance of good things happening as well. So one explanation for why people may buy lottery tickets is that they overweight the chance of winning. So that's one example. Other examples have to do with the frame of reference that the economic model assumes people just kind of always are maximizing the benefit they get from goods and services. But psychologists learn that people operate from a reference level, from the place where they are, what is their current status, and are they going to make an improvement, or are they going to receive a loss by making this decision? And what we found out is that losses loom larger than gains, and that people place greater weight on losses, and so they try to avoid them. And so that's another example. Then there's a lot of other examples from social psychology where people behave differently in certain social contexts. We honor our commitments because we want to appear consistent in how we act. So if I told you I would be on this podcast today, if I didn't show up, you'd say, "What a bum, he didn't show up." So I honor my commitments. I also respond to how other people behave. So looking at the actions of others, what we call social norms. If I find out that other doctors are doing certain things, I may follow along and try to do those things too. So those are some examples.
That's definitely true. I see that as a clinician, like, okay, I have to offer the Tamiflu. Everybody is. I don't know how much it's going to help, but I'm going to be judged if I don't offer.
Yeah, that's right.
That's so interesting. And do you think, and just because this podcast is High Truth on Drugs and Addiction, those things apply to the decision of using drugs, even in youth, right? Or like, should I smoke, right? There's social norms around that, if it's acceptable or not acceptable, or the risks, right?
Yeah, absolutely. And there are behavioral economic theories of addiction that tap into some of those things, that maybe people are present bias. The present value of getting high might outweigh the long-term disadvantage when you're making those decisions. Certainly social norms play a role. And yeah, there's a lot of behavioral science that goes into addiction as well.
Just hearing you talk makes me realize why some of these surveys and like monitoring the future is so important, because they measure things like perceived harm. So as perceived harm goes down, use goes up because of exactly what you were saying. And the importance in prevention science of pushing social norms. I'm going to have some podcasts about that from prevention scientists, but the norm is that most people don't use drugs. But people may think that like everybody does.
Right. They may believe that more people are using drugs than actually are, and they can also be in certain groups where people are modeling drug use, or they see drug use and then they falsely believe that everyone's using drugs.
So, as an expert in physician decision making, does that mean that you as a researcher know how I'm going to react or treat my patients based on that?
No, that's a great question. I think one way to think about it is that physicians learn a lot of facts in medical school, and they're great at learning.
Oh my God.
They're great at learning all these facts, and they're tested on these facts, and then they go and they gain some clinical experience, a lot of clinical experience through residency, fellowship, and then through their clinical practice. But a lot of times, some of that, or at least some of that clinical experience might be biased because they don't always see all the patients come back that they saw. They don't get a perfectly random sample of patients returning to them to give them feedback on how well they're actually doing.
Yeah.
And also, there's a lot of gray areas in medicine. So you learn all these facts, and there are certain things in medicine that doctors will always react rationally to because it's very clear. You know to set a broken bone, you know to stop the bleeding, you know a lot of things that you will always do. But then there's a lot of gray areas, and I think chronic pain is one of those gray areas where, what do I do in this situation? Do I give an opioid? Do I not give an opioid? It's unclear what the outcome is going to happen. The bad outcome is going to happen far downstream, and you probably won't ever learn about it. You might. And so that makes it a very difficult decision and prone to bias, to all the biases that we've been talking about, because it's not really a clear-cut case at the patient visit what's going to happen.
Yeah, and that's true. And following the social norms, like we talked about at the beginning of my career, I gave, here's some 30 Vicodins, why all the other doctors were doing it. And, I felt the social pressure to prescribe. And sometimes the patients do that to you too. Well, my other doctors do that. Like, how come you're not doing it? Right?
Right. They use behavioral economics on you.
Yeah, that's right. And that's why the research that we did was so important and really changed my life, because I got to see a different aspect of pain medications, and really all controlled medications, compared to what my peers were seeing. When you look at what's happening in the morgue, that really wakes you up, it shakes you up, and you realize it changes your clinical decisions.
Absolutely. Yeah. In fact, I think before we started working together, you were doing a lot of work on what you call the death diaries. And I just thought it was fantastic that you were trying to characterize who were the people who were dying and what were they being prescribed and what was going on. It's such important work, and it really laid the foundation for what we did to get together to try to change physician behavior.
Right. And that's how you and I got connected. And so I reviewed all deaths from medications. I didn't want to do just opioids. I wanted to look at everything that I potentially could be responsible as a doctor. What I have, I mean, like, I'm not prescribing heroin and methamphetamine, but I am prescribing Xanax and hydrocodone and clonazepam. So I wanted everything that people die of that is labeled because of me, and looked at their prescriptions and see if there was a match. And that really was eye-opening. And then you came in and brought that to another whole nother level. But how did you, and I don't think I ever really knew how we first connected. Did you read about that or hear about that? Or is it something that you kind of wanted to do on your own?
Oh, that's an interesting story. So I had this idea. I wasn't aware of your death diaries work at the time, but I had this idea to, having worked as a clinical psychologist in a medical center and working with medical records and working with other doctors and patients, sometimes, psychologically distressed patients, sometimes they disappear and you wouldn't know what happened to them. There was no way to find out really from the medical record what happened to them, because the U.S. healthcare system is so fragmented that every medical center has its own silo of records. And so I kind of knew this was a big problem. And then as the opioids crisis was increasing and getting worse, and there were newspaper articles every week about how now, 90 people a day are dying. Now 120 people a day are dying. This is before fentanyl or anything like that. This was just prescription drugs. You talk to physicians and they generally felt like it wasn't a big problem, but that it wasn't really a problem in their clinic. And it occurred to me that that can't be the majority of physicians can't believe that and that be true. If it is a big national problem, it means that at least some of those clinics, patients are not doing well or dying. And I thought it was important, it's a duty of a physician to learn about what happens to their patients so they can provide better care. And that wasn't really being provided to them by the medical system. The medical system wasn't really set up to give them any sort of feedback. So I had this idea that we should link these data from the medical examiner with the cures, and which is the state controlled substance monitoring database, and just let people know, not really blame them, but let them know that this happened and you should be aware of it, and then that can become part of your clinical practice. Querying people about their use and trying to help them out, perhaps being more careful with their prescribing. And so I had this idea, and I first I went around to find out, is anyone doing this, and I couldn't find that anyone was doing it. I did talk to a reporter named Eric Iyer. He's now famous. At the time, he wasn't famous, but he won the Pulitzer for his reporting on the opioid epidemic in West Virginia. And there was I can't remember if it was the DA or a medical examiner who was interested in doing this in West Virginia, but they never did it. So then I talked to someone we both know, Mike Manchin, who's a co-author on our paper. And he said, you have to talk to Ronit Lev. She's doing these death diaries, and this is the way to do this. So Mike really helped out a lot in making the connections between myself, you, and John Lucas, who was at the time the deputy medical examiner at San Diego, and now is the chief medical examiner in Los Angeles.
Yeah, that was a great connection. Makes me think that whenever you think you have a brilliant idea, there's someone else in the world who also has the same idea. But that research, again, as a clinician, really changed me. I kept thinking, what if it's my name next to somebody? And it really shook up our community, because physicians, just like you said, it's like, okay, well, that's not my patients. And if it was my patients, because they didn't take their medications right, because I'm practicing good medicine. And then doctors, people don't realize, but when patients die, they don't tell their doctor. The family doesn't call them. We have no idea. They just, exactly what you said, they just disappear. So I'm wondering, was this research as an adventure for you as it was for me?
Oh, absolutely. And in a couple of different ways. One, I felt like at the time there were people like you, John Lucas, Mike Small at Cures, and a few other people, Kelly Pfeiffer, who's now at the state of California mental health, who were very concerned about this problem and felt an urgency and that nothing was being done. And so it was great to pull together all of you guys and to work on this together and make it happen. And it felt like an adventure to me. I learned a lot. From the Cures data about kind of the process of death and how that unfolded over time for these people. And I hope we communicated some of that in our publication. I know I got a lot of feedback from physicians after reading the article that, they were surprised that patients near the end of life were going to so many different doctors. And I have a different take on that. I don't really like the term doctor shopping, because I think it puts a lot on the patient, and as that's their fault or that they're doing something bad. I think what we learned from that about the course, the natural course of their opioid use, was that most of those patients started out dutifully taking opioids as their doctor had recommended. And then after some point in time, they developed an addiction and then needed more and more. And eventually, after maybe a year or 2 years, started visiting more and more doctors. So I don't like the narrative that, patients in a premeditated way decide to go to 5 or 6 doctors to get opioids because they want to get high. I don't think that that's.
It's not, but I remember you our other partner in the research, Andy Wen, created this, I don't know if it's called it's a dynamic way of seeing things. And you could see, like, he had little dots for patient and squares for doctors. And you could see as time went by, you'd have more of these webs, and more webs meant more chances of death.
That's right.
So, and I thought that was just fascinating, because what you could do is you can predict death and prevent it. by showing those models. And I agree with you. I don't like doctor shopping because it's accusatory.
Right.
But the definition that for the cures definition for doctor shopping, they don't call it that, is like if you're seeing six
Right.
doctors and
Well,
six
no, it's a
pharmacies.
risk factor. It's definitely a risk factor for death, and we need to pay attention to it. But yeah,
So we created a gold standard instead. One doctor, one pharmacist to coordinate all your controlled medications.
Yeah.
You need to have a quarterback
That's right.
for your prescriptions.
That's right. I think
Right.
that's the way to go.
And then I don't know if you remember, one time we had a conference call because you had a statistical variant of a doctor who had like 10 deaths. Do you remember that?
Yeah, I do remember that. Yeah, we had, I think it was definitely an outlier. I mean, some physicians had 4 deaths, but there was a doctor that had a lot of deaths.
So that gave me pause in that conversation, because when I did the research 2 years before, I had a doctor with 4 deaths, and I thought he stood out, and I thought, I don't know, I kept everything confidential, and any doctor names or pharmacists or patients, that never went out to anywhere, and I didn't act upon it. But I felt, when I heard that this potential, I didn't know who it was, now went up to 10 deaths, now I felt I was conflicted ethically, that if I should say something or do something, because that just really stood out. And I drove down to the medical examiner where the database was and looked it up. And as I was scrolling through the names of doctors, I saw my name and freaked out.
But you weren't the 10. That you were not the 10.
I was not the 10. I had the 1, and my prescription was 18 months before the person died for 10 Vicodins. But it alerted me. I went and looked at the case. It was actually, I remember it was a lady who had an orbital fracture, and the plastic surgeon said, "Oh, Ronit, can you please give her some pain meds?" And I just did. And I didn't even notice that. And I wouldn't have a way to notice that she just got 150 pills. She didn't need my 10. And I didn't kill her, but I didn't do something to prevent her from dying.
Right. And that's the point. It's not that it's your fault or anything like that. It's that it's just, as a clinician, you want to be aware of a lot of things. You want to know more about the patient than is written down in the chart, or, what they tell you, things that just will help you out in making the right decision, and knowing that some of your patients are, eventually dying from opioid overdose kind of gives you pause. It makes you think, next time I'm prescribing 10 Vicodin, maybe I should talk to them about, are they receiving from other doctors, or go check out cures.
Right. Or you have a drug interaction with all the Xanax and your Suboxone, and maybe we should taper you on something, or let's maybe transfer you to Suboxone, or, that you're at risk. I had 2 of those patients last night in the emergency department. One guy just had 168 Vicodins from Kaiser, and he was there to get more from me because he didn't want to take them, so he threw them away. But now I'm supposed to give you more. Like, again, these are the things that I learned, and I even wrote about how to say, well, that's not safe for me to do now. If you want, I could transition you to Suboxone. We can get you treatment for opiate use disorder, because I think you have that. And then he bolted. He didn't. He didn't want any of that.
He wasn't ready. Yeah.
He was not ready. So that research was definitely an adventure. And what did you take out of that, from the results in that process?
Yeah. So we've now had 3 papers published on this study. One was the original paper, and the original paper showed that there was about a 10% decrease in opioid prescribing in the intervention group that received the letter 4 months after receiving the letter. And in addition, there were fewer patients on high-dose opioids and fewer new starts, or new people started on opioids. To me, the new starts are really important, because I think that's where people get hooked in and eventually go along the path, at least some of them.
Upstream prevention rather than
Yeah,
downstream.
exactly. So that was a nice paper. And since then, we've published two other papers. Some of them have been a little surprising, the results to me. One is that there were spillover effects. A spillover effect is when you do an intervention to tackle one problem, but it has, in this case, a positive effect on a related issue. And one of my students, Marcella Kelly, was interested in looking at benzodiazepine prescribing after receiving the letter. And the positive spillover in this case would be something like, well, I'm going to be generally more careful with all my scheduled drugs, not just with opioids, now that I got this letter. And she found that that also significantly decreased, and in a way that was quite good, that it resulted in sort of moderate reductions amongst chronic users of Xanax, which is good because that can also lead to death. There's about 8,000 deaths a year from benzodiazepines like Xanax. And so keeping the people who are on it chronically, and guidelines don't recommend they be used chronically, but they are because people end up getting on them. Keeping that at bay is really important. So that was a good study. I was happy with that result. And then today, our third paper comes out in JAMA Network Open, which looks at the long-term effects of the letter. So you got this letter, and how did it affect you? How does that work? Is it like a COVID shot where it only works for 4 months and you need a booster shot? Or do you internalize the letter and it changes you so that it becomes part of your practice for a long time? And what we found, we compared the 1 to 4 month change to the 4 to 12 month change.
So you took the 400 doctors who got a letter and compared them to 400 doctors who didn't get a letter?
We did. Exactly. We did that. And we looked at the original science result, 1 to 4 months in our statistical model, but then we added time, 5 to 12 months, to say, well, what happened after that? So that was a separate estimation. So they were decreasing their prescribing more often or more at a greater rate in the letter group 1 to 4 months, but were they also doing that 5 to 12 months? And we found that that in fact, there was no difference between 1 to 4 months and 5 to 12 months in the intervention group. They continued their steady reduction of opioids at a moderately higher rate than the control group, who was also reducing because there's a lot of pressure to reduce prescribing. So what that means is that the letter had a lasting effect, that you only had to receive one letter to have an effect.
That letter was a shock. It's like giving, electricity to the heart, like, VFib,
Yeah. I think one of the interesting things about the project, and you'll remember this, is that we had to figure out how to write that letter in a way that would appeal to physicians, to bring them in, to make them want to be part of our group of people who were trying to make a difference and make a change, to not push them away. And just knowing that your patient died, you're right, it is like a shock. And I think we all felt we don't need any harsh language in here. What we needed was very empathetic language. We told them that we know it's difficult to learn about your patient's death. Come and join us and help fight this by using cures, following the CDC guidelines. So I felt like we tried to make them part of the in-group. We didn't try to ostracize them and say, oh, you're a bad doctor. Just like, hey, this happened. And yes, it's a shock and we understand, but we'd like you to join us and help. And I think that was really important.
The letter referred them to a website that had educational information. And
we referred them not only to the CDC guidelines, but to the San Diego Safe Prescribing group, which maintained a lot of safe prescribing materials.
Yeah.
And I remember our program officer was like, I didn't know how you were going to do it. Write that letter in a way that sounded kind, but you did it. So
I think most people who got our letter were understanding, and it gave him pause, and I think it did. It gave him like a shock of,
Yeah.
and that's people don't understand that as a doctor, taking care of patients not like a business. It's your soul, right? That's hurt. Like you never want to hurt anybody, and it really affects us emotionally to have that. So
And I think part of the shock is not so much the letter as it is the way the medical system is set up. It sort of unintentionally shields doctors from learning about these outcomes because the healthcare system's so fragmented and patients just disappear. You just don't get the information. So it's kind of like you're waking up to this fact. You're like, wow, this really happened. This is reality. This really happened in my practice.
yeah.
And that's important.
So I learned a lot about, because I'm thinking of how to fix things upstream, um, and you know how you deal with infectious disease a lot and publish about that, right? And every year we get an antibioticogram, right, of what antibiotics work for certain infections or bacteria where there's a resistance, and it gives an annual guide to physicians on how to prescribe, because it changes from year to year. One year E. coli, it's Septra works, and the next year you need to use Keflex, a different antibiotic. So and it changes, and that's published, and we use that as a guide. I thought this information from the medical examiner can be used in the same way as we have that information for antibiotics, because risks of certain medications change from year to year. So when we studied it, I learned that 90% of everybody who died was on a chronic prescription for 3 months or more. 96%, that's the high risk group. That's the people you need to be watching, right? I learned that 80% died of a cocktail, not just one drug. If it was one drug, it was methadone. So we got to be careful with our methadones. I saw opioid and benzodiazepines was 50% of everyone who dies. It's like, okay, that's our high risk group. And surprisingly, when I looked at the quote unquote doctor shoppers, maybe we need a different word for it, but whatever that definition is of going to more than, I think our definition was more than 4 doctors and more than 4 pharmacies. They were not the majority. They were very much at risk, but they were 28% of the total, but they consumed half of all the drugs. So again, another one. But what do you think, because you've studied on a high level research, both infectious disease and medication deaths. What do you think of applying the analogy? I always tell my listeners know that I'm jealous of like Shigella and diarrhea and COVID because they get all the attention. But I think some of these models can apply.
Yeah, I absolutely agree. I think there's a lot to be done in antibiotics, and some of the adverse outcomes, the severe adverse outcomes, are more rare. Certainly not, some of the adverse outcomes are not rare. But, one example I think is in pediatrics with ear infections. So it turns out that 70% of children who've had C. diff, which is an infection brought on, it's an opportunistic bacteria that sort of invades the gut. It's always there. We all have it, but it sort of takes over the gut after antibiotics, and it has some toxicity to it. It creates, diarrhea, upset stomach. It can cause death in people who are not healthy. And so it's very dangerous, and it's disruptive to children because they're trying to grow and get nutrition, and it can be bad for them. But it turns out that of children who have C. diff, 70% were given an antibiotic for an ear infection 9 to 11 weeks prior. And so that's something that's important to know. I think doctors should know, hey, you gave this for an ear infection, and the child got C. diff. And so that type of thing might give them pause and say, hey, let's wait a week, see how the ear improves, or let's try this other strategy. I think a lot of this can be applied. And there's a lot of really important work going on in antibiotics about trying not to use these highly potent specific antibiotic, or I'm sorry, the general antibiotics that kill everything, and work with the more general antibiotics, shorter courses of antibiotics, that we don't need the longer courses. And I'm not an expert in this. I'm not an ID doctor, but I know ID doctors who are pushing this based on the evidence. And so I think a lot of stuff that's done in medicine is based on practice or sort of a habit that they said, well, one of the Brad Spellberg, who's a well-known ID doctor, talks about how, why are a lot of therapies a week long? Well, it's because there was a Roman emperor who decreed that a week would have 7 days, and we would, have this thing called a week. And some courses of antibiotics don't have to be that long. We just kind of arbitrarily pick that because it fits within our framework of how we think about time. So I think there's a lot that can be done in notifying people of bad outcomes that could improve medicine, make physicians more rational.
The other intervention that, we give the antibiotic gram, and I don't know if you've ever done this. We measure whether doctors follow the change in antibiotics. And I'd like to do the same thing with drugs, is show, at least that once a year, give the medical community, these are the drugs that are in the community, both a medical examiner, what is being seized by a sheriff's department, because we don't know that there are all these methamphetamines and opioids, and this is because of that, kind of like we did with the death diaries. And because of that, this is what you should do: give naloxone to anybody who uses any drugs, not just opioids, and refer for treatment. And here's a phone number, and beware of these, medication combinations.
Yeah, I think that's the next step that we really need to address, and it has to do with the fentanyl crisis. So we had these twin epidemics of prescription drugs and then fentanyl, and fentanyl has now overshadowed prescription drug deaths because it's such a potent
by a lot, right? We were freaking out
absolutely.
by the prescriptions deaths, what you were saying, 100 a day. Now it's like, 600
Right. And so,
a day.
exactly. It's crazy. And but it turns out that nationally, about half the people who die of a fentanyl overdose are also getting a prescription drug. So there's an opportunity for physicians to talk to patients, to do screenings, to determine if they need naloxone, to determine if they need Suboxone or other medication-assisted therapy. And so I think that's really the next step, is to tie these outcomes that have to do with illicit fentanyl with visits that happen at the doctor's office, and say, hey, some of your patients.
I didn't know that. 50% of everyone who dies of a fentanyl overdose was given a prescription.
As of 2020, yeah, with CDC data, yeah.
That's important to know.
Yeah, I mean, it's a polysubstance problem.
And is it a drug of abuse, or is that 50% also getting Suboxone, which is part of their treatment? But
and that excludes Suboxone, as far as I know. Yeah, that's it's really, the drug use, it's really a polysubstance epidemic. Right. Methamphetamine, fentanyl,
right,
prescription drugs. And we have these nice categories where we're, we these are prescription drugs, and these are, but a lot of the people who are using drugs are going to multiple sources and getting.
Right. They die of a cocktail. When we showed that 80% die of a cocktail, not just one drug.
Yeah. So there still are opportunities, even in the illicit space, for physicians to have an impact, because many of their patients, they may not be aware, are at risk for fentanyl overdose because they're using illicit drugs.
Wow. I think that's an important public health message, right? 50% of people who die went to their doctor for something. I wonder if you have more details on that, so we could educate that, and therefore you should do
I think
ABC.
Yeah, it's to be clear, I'm not 100% sure that they got the prescription medication at a visit, or if that includes medications that were diverted. But at any rate, the point is that the prescription drugs are playing a role, and there's opportunities to.
Exactly. Just like that, my case example that I said, where my patient died. I I didn't kill her with my 15 Vicodin, but I didn't intervene to someone who was at risk.
Right. Right. Yeah.
And people, doctors would be, well, what could I do? I'm not the one prescribing them, but I could have had, at least for my conscience, at least have a conversation that, like, I'm worried about you.
Exactly. Yeah.
Medications. Just, at least that I could say, I'm worried about you. These company, I've seen people who died from this, and here, you can get treatment for that or help with that. The problem is the help is different place, maybe with the doctor who's giving her, right? Like I had a lady who's getting, all these Xanaxes, 1 milligram 3 times a day, and she's still running out, weeks ahead of time. And it's like,
Mhm.
how do I make that intervention but it's possible.
Right. Yeah, it is possible. And physicians are the gatekeepers for addiction treatment, medication assisted therapies. And so they need to find creative ways to know when the patients that come to their visits, or people in the household even,
Yeah.
are at risk, and how they can help.
That research we did together, again, is amazing, and you got it published with Science magazine, very prestigious. You were saying, okay, let's start with the highest level magazine possible. We'll go from there, and it worked. It not only worked, but you got the eye of Dr. Nora Volkoff, the head of the National Institute of Drug Abuse, who wrote a commentary on our research, and she thought it was brilliant. So that was
nice to have her write that, and to explain to others what we did. I thought
And
that
it got me a lot of brownie points, because when I met her in person and she said, there's someone who did this article in San Diego and letters to the medical examiner. I said, yeah, that was me. And she got, that was you? I didn't know.
that's great.
So yeah, so I got you helped me out with that. Natalie is a physician assistant that I work with. She's amazing in the emergency department, and she learned about the death diaries, and she wanted to know, in 2015, we had 800 physicians. That's a heck of a lot, who prescribed to people who died within 1 year. And is that still a problem? So you did research, right? Looking and showing that the 400, half of them, they prescribe less. But is it a problem today? Do we still need to be sending out these letters?
I think the letters need to change, and I think it's less of a problem today. I think there's been a lot of pressure on physicians to prescribe fewer opioids. We're still at a higher level than we were prior to OxyContin being released. So in the 1990s, you were pretty safe going to the doctor. They were very concerned, mid-1990s, they were very concerned about opioids and how many they gave you. And they were rather stingy with them.
Well, there was also this triplicate prescriptions, right? You could
Right.
not write for oxycodone unless you had one of these expensive,
Triplicate
prescriptions,
forms.
triplicate forms that you paid for, and you had to keep records of them for many years. So unless you had one of those, you couldn't prescribe. I remember working in the hospital, and I wanted to have one of these triplicates. So I went, I wanted to always be able to help. And so I'd have like an oncologist come to me in the middle of my shift and say, hey, could you write my patient some morphine? He can't get it, and it's like, okay, yeah, sure. That's why I did it.
Mhm.
And
Yeah. That's another aspect of behavioral economics, which is really interesting, this idea of sludge. So the triplicate form created a lot of sludge that made it harder to prescribe controlled substances. And I wrote an op-ed with an economist from Finland named Lisa Lane. And it was after this debacle that happened with some collusion between opioid manufacturer and a electronic medical records company, where they wanted to make prescribing easier by coming up with pain plans for people, and they paid the electronic medical record company a lot of money to build in these pain plans that would go out to everybody, and it increased prescribing. But it also turned out that in Finland, they had something similar to the triplicate system that made it very hard to prescribe. And it was all written by hand, and records had to be kept. And then the government decided to streamline the process and to make it more effortless to prescribe. Just like all of medicine, they thought, well, technology's coming and we need to update, we need to move forward and update. And so they made controlled substance prescribing in Finland very easy. Press a couple buttons and you're done. And the result of that was more benzodiazepine deaths, more uh, addiction, and more suicide by benzodiazepine amongst youth. So this idea of sludge is important too, that sometimes policies that seem like a bureaucratic burden are actually helping hold back the dam and making it harder for bad things to happen. And so I'm not against the triplicate prescribing. I think it's something that can help make things a lot safer for patients.
Right. I mean, yeah, what we did, and we saw that effect overnight, right? Overnight, there was no one prescribing oxycodone, no deaths, and then as soon as they got rid of the triplicate, guess what? Oxycodone's right up top of there. And because we also got a message of social norm, like this is what they want us to do. The government wants us to push these drugs. They're making us take pain management courses. We were coerced and to prescribe. And so you make me think of something new. So just recently, hot off the press, Congress passed the MAT Act. And what that does is it gets rid of the X waiver for prescribing buprenorphine. Yay, great, right? We always was the X waiver. This is stupid. We don't need it. And what the Trump administration actually got rid of both the X waiver and the 8-hour education and said, now everybody could prescribe. The Biden administration came in and said, no, that's not how you do business. Reversed everything and kept the X waiver, got rid of the 8 hours of education, kept the X waiver. So now that was kind of okay. You had to, within 2 minutes, you would have to go to the government website, register, and now you have an X waiver. So, really all our doctors are X waivered in the emergency department. And I, like every doctor in the country, it's really, you could spend 2 minutes and get online and do this. It's still a barrier. What this MAT Act just did, I think it's horrible, but I want to know your reaction. People don't agree with me. But they put in the 8-hour education back in and got rid of the X waiver. Like, really? Do you not know how doctors think? Like, we don't want an extra click in our work. If I need to click 2 more clicks, I'm not going to prescribe, right? Or I'm not going to do that. Now you want me to take 8 hours of, I don't even know what you're going to ask me to teach me about. It'll be whatever social agenda you have or whatever, who knows? Or is it, when government meddles in medicine like that, it's just not good.
Yeah, I think that's an area where we need less sludge is buprenorphine prescribing.
And they just created 8 hours of sludge. I need to learn that from you. So it's called sludge. And does it mean like to go slow, or is it out of?
Yeah, it's like molasses. Like it's now becomes harder to prescribe buprenorphine because you got to do these 8 hours of administrative.
And that's how Congress works.
Sludge can be bad depending on how it's applied, right? And in this case, it's potentially bad because it'll discourage doctors from being able to prescribe buprenorphine. And that's been a longstanding problem. And there's many problems associated with doctors getting doctors to prescribe buprenorphine. So some of it is that doctors they have their set practices, and a lot of them don't really want to work with a difficult population or change the makeup of their cohort. And so they'll get the X waiver and then they won't prescribe. We see a lot of doctors get the X waiver when it was available, and then they would never use it or they would rarely use it. So there's a lot of inertia around, like, there's a lot that has to be done to use the X waiver or to change your practice to use it. And there's a lot of effort that has to go into that. And you're actually changing who you're treating and all that sort of stuff. There's been a push to distribute buprenorphine in the community to get people kind of started on it through emergency departments. There was a big study at Yale that showed that you get a lot of people on buprenorphine. But there's always been this issue of follow-up. Who's going to follow up with this patient and provide continued prescriptions? I actually think that telemedicine might be a way to do that, if once someone's been evaluated carefully in person and has received an initial prescription, they should be able to get refills through telemedicine. And there's been waivers during the pandemic for scheduled drug prescribing and telemedicine that I think have had a negative effect. So there's been companies like Cerebral that have been prescribing too many ADHD medications, and there's a lot of podcasts and articles written about Cerebral, and they appear to be in a lot of trouble for doing this. But there's the positive side, which is that buprenorphine could be used through telemedicine as a way for people to regularly get their medicine. So that would be a way to reduce sludge, I think. And then those doctors wouldn't have to worry about becoming, every doctor doesn't have to become a mini addiction psychiatrist. That's, I think, what the idea originally was. I think we can find ways to get people these prescriptions who need it that don't require that.
Right. And you could, somebody has very complicated diabetes or high blood pressure, right? You'll go to the cardiologist who will help adjust those cardiac meds, but they'll be continued by the primary care doctor, right? Or you'd go to the endocrinologist to help fix your, and really get your diabetes under control because it's a difficult case. But then your primary care doctor continues that. And that's the model I see working with addiction.
Yeah, that's fantastic. Right. That it's really not that we need to get a lot of people started on these medications and manage properly, and then kick it back to the primary care doctor. Don't make them do 8 hours of education, but for them to manage.
Someone needs to do the study of how many doctors signed up to do buprenorphine before this MAT Act and how many after. And I think, they're going to show that they just created sludge. You taught me a new word.
I think so.
So what lessons can we learn also from the research that you did on the current opioid crisis? Like, you studied prescription opioids. I would say we no longer have that as an epidemic. Like you said, it's not baseline to opioids to what it was in the 90s, but maybe we were underprescribing then. But we've greatly reduced it so much that IQVIA, that studies the number of opioids that are prescribed every year, are no longer even tracking that because it's not a problem enough for them to track. But what can we learn from that whole experience to our current problem with fentanyl?
Yeah. So, as I mentioned, I think the big issue now is how do you interface physicians, who are kind of the gatekeepers for medication-assisted therapy, with the people who need it. And we've talked a lot about that. One is through emergency departments, getting people started on buprenorphine. It's not always easy getting people started on buprenorphine. There's different ways to do it. And some people believe you need to, bring people almost to a quasi-withdrawal level and then start them on the buprenorphine for safety reasons. I've also heard from some emergency docs, and I don't know if you've experienced this down in San Diego, where I know there's a huge, fentanyl distribution problem. Yeah. It's harder to start people on buprenorphine because fentanyl now is so powerful. And where do you start? What starting dose do you use? I don't know if you've encountered that, or if your colleagues have.
There is a controversy on that. Do you start the regular dose of 8 milligrams and go from there and go up? I've heard both sides, you have to do microdosing if they're still on it and then go up, or no, we're going to hit them big with 24. So I've heard both ends. And as a busy ER doctor who, I've just been doing the regular amount on everyone and haven't heard feedback that that's not a problem. That's not good. I have, I've had people who say, I don't want to be on buprenorphine. I don't like it. It doesn't work for me. I think they still are seeking opioids and they don't want that naloxone. They're still in the denial, or maybe they did have a bad experience.
Right. Well, so there you've hit on the nail on the head of what I think we can learn and what can be done. So this crisis is so dynamic with changes to the drugs that are being used and the potency of the drugs. Now we're dealing with people in these really highly potent drugs. And physicians themselves are unclear. Do I microdose? Do I hit them with a lot? Do I do the average? And if you've prescribed a scheduled drug, a buprenorphine as a scheduled drug, even though it's a medication-assisted therapy, now we can track outcomes and see, are medical examiners seeing any of your patients come back are there adjustments to your dosing that can be done? Can you get feedback on how the patient is doing? Can we trace backwards from a person's death and try to learn whether they were able to fall into some type of continuity of care for buprenorphine or not? And where are the gaps?
So if you have we can do that. I'm sure Dr. Lucas in LA would be looking at it. And then Dr. Campman, our medical examiner in San Diego, would be really into that as well. So we'd be happy to participate in a way to look at that. We could look at all buprenorphine deaths. And I think at the time there were maybe like only 4 total. So now we could see if we're seeing that as well.
Right. Or I wouldn't even call them buprenorphine deaths, but people who were prescribed buprenorphine, maybe they weren't taking it. Maybe they stopped taking it or couldn't get refills.
Oh, so we'd be doing the opposite. So with our study, we took a list of people who died in San Diego and then gave the data to Cures. Now we'd be working the other way around, asking Cures to give us data.
People who died of fentanyl and who had been given a buprenorphine prescription. What failed? Where was the failure points in that?
Yeah, we could definitely do that. That'd be interesting. Well, I learned, that's interesting. That's not where I was taking out of the whole opioid crisis. I feel like we had a problem. The supply chain was the medical community. We ended the crisis through the supply chain. We didn't end it through the treatment aspect. Like, we had patients with a bucket of medications, and it's like, what am I going to do? My job is to keep you alive. I don't, I'm not going to fix this, but I at least want to keep you alive. I feel like that's what opiate use disorder treatment is. And so for me, if I want to really end the fentanyl crisis, I have to look at the supply part. And the supply part is not the medical community. It's China and Mexico and going upstream like that, which is not our specialty, right? We're, in the medical community. But I think the answer is there. Declaring fentanyl a weapon of mass destruction, making, drug dealers and that whole economic market of drug sales not so lucrative. We could do that if we wanted to.
One thing that discourages me about the addiction policy field is that there seems to be 2 camps, and one camp basically wants everyone to just be able to use drugs and to seek treatment when they're ready. And then the other camp wants to do interdiction and, come down hard on China and Mexico. And that's the answer. And I think it's probably 50 or 60 things we need to do to address this problem. And those are just 2 things, and neither of them are going to be deal breakers, but they're both very important. Right. So I think it's very important that we try to restrict supply and we put some pressure on that. But it's also important that we, don't stigmatize drug use and help people seek treatment and understand that they can be in a safe place and receive treatment.
So, stigma is interesting because everyone who talks about drugs, it's like, oh, we need to eliminate the stigma. And stigma towards a human being is bad. And as a physician, you should never do that to anybody. If somebody is smoking cigarettes, they're not a bad human being, right? They have an addiction, right? Or it could be your friend. But that act of smoking is not good. And it's stigmatized. And that's how we got people to smoke less. And if you're on the camp of, well, anyone can use drugs, we should not stigmatize people. We should not stigmatize the people who use drugs. But yeah, using fentanyl, that's not good. That's not the social norm we want to create in our society or for our children or for our future. I don't think so.
I would say pretty much the same thing, that there's a distinction between stigmatizing a person and stigmatizing a drug use or behavior, and that we do have to, it doesn't help the opioids crisis to say that opioids are wonderful medicine and we should be prescribing more of them if we need to. We need to recognize that they are also a dangerous medicine, and that opioid use can be problematic and deadly, and the person using them needs help. And if you actually look at what Purdue Pharma did they tried to stigmatize the user and say that the drugs were good, that, oh, there are some bad people and they're using these drugs, and we just need to get some predictive algorithms together and figure out who they are so we can not let them use it and let everyone else use it. When in fact, most people, if they're exposed to opioids long enough and in high enough doses, will eventually form some type of problem with them. So
the other thing that they did is created terminology, right? Like I'm just dependent. I'm not addicted. But one thing I learned from our research is like, when you're dead, it doesn't matter if you were dependent or addicted. It's the dose that you got that killed you.
That's right. It's a gray area between dependence and addiction. A lot of people won't recognize that, but if you talk to people who went into heavy use and addiction, for a lot of them, there was a period where it was hard to tell if they were just dependent or addicted. Those are human constructs and distinctions that we make. They're not, they're negotiated amongst people. They're not some sort of objective fact. Those terms, dependent and addicted. So yeah, it's we need to pay attention to both, I think.
Interesting. Now, I don't know if you know that about the same time we sent our letters, unbeknownst to us, the state of California, the Medical Board of California, sent letters to 500 different doctors based on medical examiner data, accusing them of killing their patients and threatening their license, and freaked out the entire medical population, all the doctors in California, to not prescribing. And I guess I will say this on the podcast, that I believe the Medical Board of California has blood on their hands, because when they cut off patients who were in chronic pain and scared the crap out of doctors from prescribing any pain medications, people committed suicide and they died, literally, because of this policy and those letters that they wrote. And then I don't know if you got pushback, but I got people angry at me because they mixed up our really nice, beautiful letters with the crappy ones from the medical board.
Yeah, there's a journalist, Cheryl Clark, who wrote a piece in MedPage Today in 2020 about contrasting our letter to the medical board's letter and contrasting the outcomes. And I thought it was really well done. I haven't gotten anyone mixing that up, although I suppose it could happen. But I think it points to the fact that we don't want to accuse doctors or threaten them, that just makes people defensive, that, a lot of people are caught up in were caught up in prescribing opioids because they were told that was the best thing to do, through, pain is the fifth vital sign, and a lot of these initiatives that were really being funded by industry. And so they're not, bad actors, and they just need more information, and it needs to be handled carefully and in a kind way. And I don't think the medical board, their role is really not to address the average prescriber. Their role is to address the very small number of bad actors in medicine. There will always be a few. And so for them to send out, hundreds of letters just doesn't make sense to me.
The letters from the Medical Board of California did cause a lot of damage and fear, and they were unfairly sent because for them to send a letter from the medical examiner, the death certificate had to be signed by a doctor. Well, there's only like 4 counties in all of California that have a physician sign them. Most of them, it's a sheriff or non-medical. So doctors in San Diego and Los Angeles, where we have medical examiners, were disproportionately getting letters and their license threatened compared to other parts of the state. So that was bad, and I'm glad they finally stopped. Right, they should have used real researchers in doing things like that.
Well, there have been a few places that have consulted with us about these letters, and I know the state of Kentucky has sent them out. The city of Baltimore, their opioid task force, sent the letters.
New York State, New York,
yeah.
That was cool. Yeah, we were the first in the country.
Yeah, when people take the time to talk to you about how do I do this right, because the details of implementing something like this really matter.
Yeah. And our medical examiner wants to do that again, going back to Natalie's question, to send letters, but they don't have that many. So they actually have, I think, funding to do these letter project again. So maybe if you think of a creative way to redo that, but they only have a handful. There's not that many.
Yeah, well, I think now
Right.
I think, well, in talking to Dr. Lucas about this, there's a couple of issues. One is that often because the fentanyl crisis has gotten so big, a lot of times medical examiners will now first test for fentanyl. I remember when we were doing this, that was the last test they do.
Right.
But now they'll first test for fentanyl and then they go, oh, we're done, fentanyl.
We don't do that. We do everything.
Okay, you do everything. Okay,
Yeah.
well, that's good to hear. I think extending it to illicit drugs, though, and looking to see if they had received any scheduled drugs along with that is just important for physicians to know, so that they know, like, well, some of your patients are using fentanyl, and it's something that you need to consider.
That's like when we did our research. Remember, a medical examiner didn't have the manpower to run a cures report on all deaths. And so they don't do that. They don't run a prescription history on all the deaths anymore. They're too overwhelmed. But if we had a project, maybe we can get them.
Right. I think that's what needs to be that. So how are they identifying the deaths then?
Just by toxicology.
Oh, right. See, I think that's going to come up with a very small number as compared to if you were to put the person's name in cures and identify who is prescribing to them.
Right.
Yeah.
Right. But we can, I don't know, if we want to have a conversation with him to do something, I bet we can do something.
Sure.
Let me pick your brain about other research potential collaborations. I called you a few months ago, or was it last year, where I did a baby study. You do like these massive, science journal studies. But I just did a little study just to see if people want to know about marijuana and drug interactions with their prescriptions. So we went to 17 different pharmacies, sent out 10,000 info cards, got feedback from, maybe less than 10%. I'm told it's good for such surveys that just go to general public, but it's a small number. But over 90% of everyone wants this information and thought it was important.
Great.
And I'm actually going to talk to the legislator about asking the Medical Board of California to start doing this on a regular basis. Like, you're getting information about, don't use with alcohol, don't use with grapefruit juice. Well, if you're using certain drugs, especially blood thinners, you should not be using them with marijuana products because that can increase your chance of bleeding, and that has happened. And so I want to pick your brain on, is there anything that you see from that idea that you can do on a larger scale?
I think that's really interesting. I think there's one state, and I'm blanking on the state. I'm not sure if it's Massachusetts. There's one state that requires dispensaries to enter data into the prescription drug monitoring.
Oh, there's about eight states.
There's 8 states now.
Yeah,
Okay.
that require, they treat marijuana as a medicine. So if you're going to put opioids and Xanax on the prescription drug monitoring system, then you might, and you're calling it medical marijuana, not the recreational one, then that goes in the database as well.
Yeah, and I think that needs to happen nationally for all prescription drug monitoring databases, so that we can begin to do things like look at outcomes and look at interactions like that. And of course, you're right. If we're doing this for grape juice or for grapefruit juice, why? Certainly we should be doing it for marijuana. This is not a big ask. There will be interactions between marijuana and other drugs. And because the use of marijuana is increasing because of legalization, it's important that we look to it, just like we do with alcohol, right? If you don't take this with alcohol, or we need to be monitoring that more closely.
Right. Yeah, so maybe there's a way to do that. So why not put that idea in your head? The other idea in your head, if you want to measure outcomes, starting this year, January 1st, all hospitals in California are required to include fentanyl whenever they order a drug screen. I'm proud of that. That's the first piece of legislation I ever wrote, and it passed.
Oh, congratulations.
And we're the first in the nation to do that. So I don't know if you have a way of measuring outcomes. Like, okay, so now does that change behavior? Like, I think it does. I don't know if it does change behavior in a way where we could measure it, or you could measure it. But I think when I tell a patient, or even me as a doctor, when it's like, oh, it's positive for fentanyl, I'm going to do naloxone now. I'm going to tell a patient they're in danger. And then the patient may be like, well, some of them are using fentanyl, so they know and they don't care. But some of them, it's like, well, that's not what I meant. I swear it was only marijuana. It was only marijuana. It's like, well, maybe there was fentanyl and residue in the bong. But it makes changes there. I mean, I don't know if you think of a way. I'm just putting these ideas in your head to think if there's ways of measuring changes of behavior based on this new law.
So we have looked at that's really interesting. So the law that passed in California about having to counsel patients on naloxone and opioid risk. We looked at that at Kaiser Permanente, and we published that last year. And we did like a pre-post analysis, so it's not randomized or anything. But we found huge changes. What Kaiser did was try to abide by the law by building electronic health record screens that would do everything that the physician had to do to abide by the law. And so it did create some sludge, but also it also gave us an opportunity so that all Kaiser physicians, then we could look to see pre and post what happened with their naloxone prescribing, what happened with other stuff. And we found that it hadn't, although it wasn't intended to reduce opioid prescribing, it did have an effect, making opioid prescribing harder. Physicians became more thoughtful, and they're like, I have to put in all this effort now to do this. Maybe I could try another treatment. So it had some effect on that. It also had a huge effect on naloxone, increasing naloxone prescriptions dramatically. So I think the drug testing thing is something that's interesting from the standpoint of physician order entry. And if we can find medical systems that have decided to automate this process, maybe versus ones who haven't, and see how it changes the course of care for patients. So I'm sure that some big organizations are just automatically ordering fentanyl in the electronic health record with any drug screen. Whereas,
well, they theoretically 100% of them are doing that.
Right, theoretically, but
or they're breaking the law.
Right, exactly. Well, that was Kaiser's position with the naloxone law, was that they were going to make it automatic so that they would never be breaking the law. But I think some smaller organizations may not have the resources to program that, and you could look and compare outcomes between organizations if they were closely matched with the Kaiser patient population. Or you can just look pre-post and see how it changes outcomes. It would be interesting to see, because of drug stigma, there is also the potential that maybe for some people it could decrease ordering tox screens. But I'm not sure if that's the case. That's an empirical question. We could look to see what happens. I'd be more my hope would be that it wouldn't decrease tox screens, but that it would encourage.
I don't think tox screens, because the biggest sludge in ordering a tox screen is getting someone to pee. They don't pee readily, and sometimes we order it and it just never happens because we're not.
Happens, yeah.
If you don't really want to give a urine, we're not the police, so if you don't want to do that, but if you're like unconscious and we're working up altered mental status for any reason, and you're checking for all these other drugs, why would you not check for fentanyl?
Right. Good.
Right. We using it diagnostically and therapeutically for change.
Right.
Yeah. And then the other final thing I want to pick your brain on is I worked on a research project with the University of Maryland on emergency department drug surveillance. And we created this amazing database from all of the Scripps hospitals looking at the drug screens. So actually you could use our data, tox screens over the years, and it's available online. But what I asked that was different than the other hospitals that were collecting this data is I wanted to understand the intersection with mental health and drugs. So in our emergency department, we have patients who are waiting for months. Nobody's studying them. but they're sitting there for maybe a month, or, you'll see like 600 hours in the emergency department. And my theory is that a percentage of them are there because they're detoxing from drugs, and that detoxing and clearing your mental health from alcohol happens faster than marijuana, and which may be faster than methamphetamine, and that I have that data, but I don't have anyone to like do a deep dive and look at that answer, which is, I think, the greatest public health problem that we have in the emergency departments across the United States today is boarding of psychiatric patients, and a percentage of them are there because their drugs are causing a mental health crisis.
So are you saying that they don't get a hospital bed or a inpatient psychiatric bed either? Yeah, but they're sitting in the emergency department taking up a bed for hours and hours and hours.
And days and days.
And days and days and days. Interesting. Yeah. Right. It would be interesting to find out about those people. Is it all consecutive, or are they coming back again?
They're living in the ER. They're brushing their teeth.
Oh, that's fascinating.
In their room.
That is fascinating. I was unaware of this.
Yeah, that is our biggest problem everywhere in the country.
Right. And you want to characterize these patients and understand who are these patients and why are they there doing
right. Because then you can make smart public health policies. Like, is this, here are people who need to detoxify from drugs. Here's real mental health. We need to create more beds. We need to, we obviously do because they're living in there, but we could better define what kind of beds and where is this problem coming from? And do we have more, like studies in Europe have shown an increase amount of schizophrenia and chronic psychosis associated in cities where they have more high potency THC. We haven't done such a dive so much in the United States, but we could look at where the problem is at its peak. And I think it's peaking like every problem in society in the emergency departments.
That's fascinating. That'd be a great study. We should talk more about it.
All right. So tell us what you are working on now. What is making you excited?
Well, we're doing a lot of studies with the electronic health record and trying to change physician behavior within the electronic health record through these different types of nudges.
Besides me just smashing it with a hammer because I get so frustrated.
Well, what we're trying to do, physicians rightfully complain about the electronic health record, and they talk a lot about alert fatigue, that they get all these alerts. What we're trying to do is make sort of lasting change with the electronic health record. So one problem with the way that alerts are presented is that you have to see them over. They're mostly just reminders, right? Or just reminding you about drug interactions or reminding you to do certain things. And because of that, you just see them over and over and over. And if you're not changing your behavior, then you're just going to continue to see them, and then there'll be more alerts. And so the alerts really have to be effective at changing your behavior. It's not enough just that you present them to the person. So we've been working on different ways to help clinicians change their behavior in a lasting way through the alerts. And if you think about our letters project, now we know you just send one letter and then it has this lasting effect. They internalize it, they change their practice. It sort of sets them off on a new course. And so we've been working on these clinical justification alerts in different areas, ranging from geriatric care to primary care. Can
you give us an example? Like, so,
yeah, for example, so a lot of times when you're working in a gray area in medicine, you may say, like, should I prescribe this antibiotic? Should I not? Well, I think I'll just do it to be safe. You don't really have a good reason. But a physician should be able to justify anything that they do. And sometimes they've got good justifications, right? So sometimes there are exceptions to guidelines or things that reasons why if someone has a sinusitis for 2 weeks, you should prescribe an antibiotic because the guidelines say you should. If they have less than that, you shouldn't. But a clinical justification is like a prompt in the HR, and all it does is ask you to provide something that's accountable that will appear in the electronic health record as like part of the note that says, I did this because XYZ. And so a lot of these
And it
gray
becomes
areas,
part of your note.
it becomes part of the note. Other physicians can see it. If a patient presses the blue button and gets their medical record, they can see it. And so now you're accountable for your actions in a clinical way, right? And if you're not sure if you should be doing something or not, and you're going to get a justification that you have to respond to, or else it'll say no justification given, which also doesn't look good, then the justification serves this great purpose of always redirecting the clinician back to what is the clinical reason for doing this. If you can't justify it, then maybe you ought to think of another approach. And we're finding that it's a really great type of alert, because what it does is not only does it redirect the clinician, but also clinicians see it less and less over time because they try to avoid it. They're like, well, actually, this is a gray area. I don't have a good justification, so I'm not going to pick this care pathway. And then they don't see the alert anymore. So the alert fatigue goes away because they're becoming better clinicians. They're focusing more on clinical reasons for doing things, which is
It has to be done the right way. The ones that I have in front of my computer just annoy me. Like every
right.
single time I order a CAT scan, no matter what it is, I don't even read what it says. I can't even tell you what it says. I know it's going to cost me 3 extra clicks. I'm going to say, okay, go away so I could order my CAT scan. I don't care what you have to say.
Right. No, that's right. And a lot of those though, but there's probably no accountability. You do those 3 clicks and you're done. You order your CAT scan, and yes, imaging in the emergency department is one of the areas of concern. But this is different because it becomes part of the patient's chart. It would say Dr. Lev did not give a justification for this scan, and that could engender reputational concerns if you're like, well, I don't want other physicians seeing that I didn't provide a reason. That doesn't sound very professional.
But the problem with emergency medicine is that sometimes of us, we have a sixth sense. I can't tell you how many times in my 30 plus years in the emergency department, I'm like, I'm going to get this CAT scan. I really don't need it. I'm just going to get it. And then it's like, whoa, check out that big epidural hematoma I never expected. And so I'm rewarded both by fear and positive outcome.
Yeah.
To get those things.
Right. It's some of these areas are more difficult than others. And imaging is one of the areas that's more difficult because there are cases where you find something, but there's also downstream harms from imaging too, like incidental-omas, where you find things that create sort of bad care pathways for people that are
right. Or, well, here's one example. Anybody with cannabis, I'll bring marijuana back into the conversation. Anybody with cannabis hyperemesis syndrome, their average number of abdominal CAT scans is probably 5. And that's a huge amount of radiation that'll give them cancer later on in life. And one of the things I tell my patients is like, tell the doctor that you've had all these CAT scans so they don't scan you again. And that doesn't always happen, but that's an example. Like, if there was some alert of getting cancer for somebody with marijuana.
Right. Or this person has had this many,
age under 40 and marijuana use, and maybe, or something.
Yeah. Or telling the physician this person had this many rads of radiation, what justifies an additional CAT scan. And they've been negative every time. I mean, obviously
yeah. That would be a helpful alert.
Yeah.
Right. Yeah. Very cool. All right. Well, that's so exciting. Thank you so much. I love talking to you. You have a big, wide view of the medical community and our decisions and how to make things health better economically and public health wise, and the big crises in our society. I want to say thank you to Natalie for your question, and I look forward to seeing your warm smile on the next busy shift that we're going to be working together. And thank you, Jason, Doctor, for teaching me, inspiring me, and for publishing research that impacts the medical community clinically and inspires smart health policy.
Thank you, Ronit. I really enjoyed talking to you.
Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This week's episode would not be possible without the generous support of our sponsor. A sincere and warm thank you to Isaac, the International Academy on the Science and Impact of Cannabis, doctors educating on the harms of marijuana. Visit isaac1.org, that's IASIC1.org, To view their library that translates medical journals for public understanding, listen to their speaker series, and follow the science on marijuana. High Truth's producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Oneet Lev. We hope we brought your day a little bit more High Truths.